I'm now going to examine the central nervous system. I will already have noted the patient's conscious level and whether he's got any problems with speech. I can then turn to the cranial nerves. The first cranial nerve is perhaps the least satisfactory part of the examination. There are various substances we can get patients to smell, but perhaps it's adequate to ask the patient, do you have any problem with your sense of smell?
No.
Remembering that any difficulty with smell is much more likely to be a nasal problem than anything in the frontal lobes. I can turn to the second cranial nerve and test visual acuity. I can use a Snellen chart, but if that's not available, it's adequate again to ask the patient, do you have any problem with your vision?
No.
I can also use a tabloid newspaper which has print of various sizes if I want to take the problem further. I can then go on to the visual fields, and I do this by using my visual field as the normal and comparing it to the patient. I'll stand in front of the patient and cover up the patient's eye with his hand. I will cover up my eye with my hand and ask the patient to look at my nose. I then put my finger at the periphery of my vision and say to the patient, tell me when you see my finger moving.
No. 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 No.
And I'm using my finger as a comparison with his visual field. I can then change over and test the other eye. I can then go on to use an ophthalmoscope. Now, an ophthalmoscope has got this bit curved at the top, and that is to fit in to the curve of my face. I can put this in my eye like that and look around the room through the hole in the ophthalmoscope. I can then look through the hole at the patient's eye and come down onto the eye and see the retina. I can follow the vessels to the disc, and when I've seen the disc, I can then look round the rest of the visual fields. It's sometimes easier to have the patient sitting up or even standing for this examination, but some patients, of course, are too ill for this. To do the other side, I go round to the other side of the bed and use the opposite eye. I can now go on to examine the third, fourth, and sixth cranial nerves which move the eye. First, I can look for any sign of ptosis or drooping of the eyelid. This may be due to a sympathetic nerve problem. The sympathetic nerves run with the carotid system, or a parasympathetic problem. The parasympathetic nerves run with the third cranial nerve. I can then look at the pupil and look at the pupil's size to make sure that it's the same both sides and there's no irregularity or scarring of the pupil. I can then test the response to light with a torch, which I bring in from the side and shine the light into the eye and look for a contraction of the pupil. I look on this side and also on the other side at the same time. I can then go round this side and test it again. I should get a response on both sides when I stimulate one side. The impulse goes through the second cranial nerve and comes out via the third cranial nerve. I can also do the accommodation reflex. I ask the patient to look at the wall and put my finger in front of his eyes. Then I say, look at my finger, and look at the wall, and look at my finger. And as he looks at my finger, I can see the pupils contract. I can then look at the movements of the eye. And I ask the patient to look at my finger and follow it with your eyes. Do you see one finger or two?
One. 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 One.
I ask the patient if he can see double because he is much more able to pick up minor degrees of diplopia than I can. At the same time, I can also look for nystagmus. I can now go on to the fifth cranial nerve, which subserves the muscles of mastication. Can you clench your teeth and relax? Open the mouth. I can feel the muscles contract under my finger, and when he opens his jaw, the jaw stays in the midline and doesn't deviate to either side. If there's a weakness of the pterygoid muscles, then the jaw will move to the affected side. The fifth cranial nerve also subserves sensation to the face, and I'll come to that later. But for the moment, I want to test the corneal reflex. To do this, I have some cotton wool made into a point, and I bring this onto the cornea, not the sclera, the cornea, and I see a blink, which is bilateral. And again, I'm putting a stimulus into one side via the fifth nerve, and I'm getting a reaction both sides via the seventh nerve. I can now go on and examine the seventh nerve, which subserves the muscles of facial expression. There are many commands that one can use, but I like to demonstrate and say, do this. Do this. And I get a response that's equal on the two sides. One can ask the patient to show me your teeth, but then sometimes you get the explanation that they're false, and some enthusiastic patients actually take them out and show them. To test the eyes, one can say, screw up your eyes, tight, open them again. And to test the frontalis muscle, I do this. Can you look at my finger? That's a good way of getting patients to wrinkle the forehead. I can now go on and examine the eighth cranial nerve, the auditory nerve. Ear, nose and throat surgeons have sophisticated ways of testing this, but for our purposes, we can do this. I put one finger in the ear and move it to obscure sound to this ear and say to the patient in a whisper, how old are you?
22.
And I change ears and say, wait a minute.
Hazel Street.
I can also use a watch. I can take examination of the ears a bit further by using a tuning fork. And I can do the Rinne test and get the patient to listen in the front like that and over the mastoid process like that. And I can do that and say, do you hear it louder in the front or behind?
In the front.
That's the normal response, and also the response we get with nerve deafness. But in middle ear deafness, patients will hear it better at the back. Bone conduction will be better than air conduction. There's also the Weber test. When I put the tuning fork on the forehead and ask the patient if he hears it better in one side or the other, or the same both sides.
Same on both sides.
That's the normal response. In middle ear disease, the sound is heard best on the affected side, and in nerve deafness, it's heard best on the other side. I can now go on and examine the 9th and 10th nerves, which are not separable clinically. And to do this, I need to look at the throat. Open your mouth. And I can use a tongue depressor to press the tongue out of the way and stimulate the fauces. And I get a contraction of the soft palate, with the soft palate rising up equally on the two sides and the uvula staying in the midline. I've tested the motor output and the sensory input on both sides together. I can now test the 11th nerve. Can you lift up your shoulders? Keep them up, 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 up. The 11th nerve supplies the trapezius muscle, and also the sternomastoid muscles. Can you push your face against my hand? And that contracts the opposite sternomastoid. And this side. And push your head forward. And that does both at once. Lastly, I can test the 12th cranial nerve. Can you put your tongue out? Right out. And I look to make sure that the tongue comes out in the midline and there's no wasting or fasciculation. Thank you. And that concludes the cranial nerves. I'm now going to examine the rest of the central nervous system. And I'm going to start with muscle power. There's a large number of muscle groups that we could test, but for practical purposes, we confine ourselves to a few. Can you squeeze my fingers tightly? Squeeze tight, 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 tight. All right, let go. Put your hands up like this. Pull your hands towards you. Push your hands away. Push your elbows away from your side. Tuck your elbows into your side. I've done grip and flexion and extension of the elbow and abduction and adduction of the shoulder. Can you lift this leg up and keep it up there? Keep it up. Keep it up. Keep it up. 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 All right. Okay. Keep it up. Keep it up. And down. Keep the knee straight, and I'm going to try and bend it. Keep it straight. Now, can you bend this knee? And I'm going to try and straighten it. Keep it bent. Bent. All right. Keep it bent. Push me away. Push away. Pull your toes up towards you. Pull up, pull up, pull up, pull up. And this side, pull up. I've done flexion at the hip, flexion and extension at the knee, and dorsiflexion and plantar flexion at the ankle. I can now go on to do the reflexes. For that, I need a tendon hammer, which has a flexible shaft and a heavy end. And this heavy end is the bit that does the work. I operate it from my wrist. Now I let the weight of the hammer do the work like that. I don't jab from the elbow. Then it's important to have the patient as relaxed as possible. If the patient is contracting his muscles and holding his arm in a particular position, then I won't get a good result. I can start with the biceps jerk, and I can put my finger on the tendon, on the biceps tendon, and let the hammer fall onto it. And I get a contraction of the muscle which moves the arm. And for the other side, I put my thumb on the tendon and let the hammer come onto it. That's the biceps tendon, which is innervated by C5. Now the supinator. Again, I must have my patient's arms relaxed, and I can strike the tendon directly. And I get a jerk of the muscles. For the triceps, I move the patient's arm across his chest, hold it there myself. A little wobble will often relax the patient, and strike the tendon. And on this side, I can pull it towards me relax the muscle, and strike the tendon. The supinator jerk is innervated by C5 and 6, and the triceps by C6, 7. I can then go on to the knee. I need to see the muscles. I put my arm underneath. I like to lift up both legs together. A wobble will relax the patient. And strike each tendon in turn. For the ankle jerks, I need to bend the knee, let the leg fall outwards, put one hand on the foot, use it to tense the Achilles tendon, and then strike the tendon. And on the other side, again, bend the knee, let the leg fall outwards, tense the Achilles tendon, and I get a response. It's important to remember that the purpose of this exercise is to contract the muscles. That's what one is looking for, and the muscles must be able to be seen, not covered up by clothes. The secondary effect is to move the limb, but that's not essential to the movement. The knee jerk is innervated by L3-4, and the ankle jerk by S1. Now I can go on to look at the plantar response, which is best elicited by some fairly blunt instrument. I stroke the outside of the foot and bring it across medially, and the movement I look for is in the first toe. On this side, I move it up the side and across medially. And the movement I get is movement at this joint, the first metacarpophalangeal joint. And it's flexion of that joint which is a normal response. Anything else is of no importance. If I do that again, the first movement is down at this joint. The response here is innervated by S1. Now I can look for any muscle wasting in the muscle groups, and in particular for the small muscles of the hand. And that's quite normal. And also I can do the same thing in the legs. Next, I can look for tone, changes in tone. Now here it's essential that the patient is relaxed. Any contraction of the muscle will, of course, increase muscle tone. I can passively move the limb and compare the two sides. Because patients find it so difficult to relax, I like a technique of shaking hands with the patient on both sides together. This is a natural movement and allows the patient to relax, and I can very readily compare one side with the other. I can also use a technique in the legs, which involves wobbling the legs under my hands like that. Again, a movement that helps the patient to relax. I've now examined the motor side of the central nervous system, and I can go on to test sensation. I can test various modalities of sensation, and I'll start with touch. To test for touch, I use some cotton wool pulled out into a wick. One's instructions to the patient at this point are most important. I'm going to touch you with some cotton wool. I want you to say yes when you feel it touch you. Can you close your eyes? And I'm going to start where I'm pretty certain the patient will feel it.
Yes.
That establishes that we're on the same wavelength.
Yes. 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 Yes.
Note that I don't go too close to the midline because the nerves cross over.
Yes. 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 Yes.
The exact interpretation of this requires some knowledge of the nerve supply to the skin, but more importantly, the dermatome distribution. Now, it's difficult to remember the precise dermatome distribution, and indeed it varies between different patients. But if one can keep a few landmarks in one's mind, you can fit the rest together. The tip of the shoulder is C4. The middle finger, the longest finger, is C7. And remember, the cervical spinous process, the longest, is C7. The axilla is T3. The umbilicus is T10. The suprapubic region is T12. The knee is L3. The first toe, the big toe, is L5. The fifth toe is S1. First toe L5, fifth toe S1. If you can remember that, you can put the rest together. That is sensation. I can now go on to do pain. I use a pin with a sharp and a blunt end. I say to the patient, one end of this is sharp and the other is blunt. I want you to tell me whether you feel it sharp or blunt. Can you close your eyes?
Sharp. 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 Sharp.
And I carry on as before. Now I can look for vibration sense using a tuning fork. I start somewhere where I'm pretty certain he's going to feel it. Can you feel that vibrating?
Yes.
Now I do it again at some bony prominences, say on the wrist.
Yes. Yes.
And the ankle.
Yes. Yes.
I can make it more sensitive by saying, close your eyes, tell me when it stops.
Yes.
A good response. Now position sense. I'm going to move his fingers and toes up and down and ask him to tell me which way they go. It's essential to explain this in detail. I'm going to move this finger up and down, and I want you to tell me whether I move it down or up.
Mm-hmm.
That's down, and that's up.
Yeah.
Can you close your eyes?
Down. 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 Up. 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 Down. 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 Up. Up.
Note how small the movements are and how easily they're appreciated. Now the toes. That's down, and that's up. Close your eyes.
Down. 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 Up. 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 Down.
Quite normal. Remember that in elderly people, they're likely to have some disturbance of sensation, particularly in the feet, and that's not necessarily pathological. I can now go on to examine coordination. Coordination is normally thought of as a cerebellar function, which indeed it is. But it's important to be sure that the patient's motor power is normal and proprioception or position sense is normal, because both of those will influence the interpretation of the tests of coordination. There's a large number of possible manoeuvres one can get a patient to perform, but we do just a few. Can you put your arms out like that? Keep them there, and I'm going to try and press them out of the way. The arm returns very readily to its former position. In cerebellar disease, the arm will have a big displacement and will tend to jerk like that. Then I can do the finger-nose test. Can you put this finger on your nose, and now put it on my finger? Now your nose, now my finger. Now your nose, now my finger. And the other arm, now my finger, now your nose, now my finger. Quite normal. In cerebellar disease, the finger will tend to jerk on its way and may overshoot its target. You do this, and like this. This is called dysdiadochokinesis. The arms are moved equally on the two sides and are coordinated. In cerebellar disease, this coordination breaks down and it becomes irregular. We can do the same sort of test in the leg. This is called the heel-shin test. I want you to take that heel and put it on the shin and run it up and down like that. Carry on yourself. Patients have difficulty understanding this manoeuvre unless it's explained properly. That's quite normal. In cerebellar disease, this will tend to be a jerky movement like that. Can I just drop the bed? Two more tests for meningeal irritation. The first is neck stiffness. I put my hands behind the patient's head, relax the head, and then lift the head up with my fingers, assessing whether the neck is stiff. Sometimes necks can be stiff in this direction as well as in this direction. And if so, that's usually due to disease of the spine, not meningitis. Meningitis just gives stiffness in this direction. And a similar test for meningitis is Koenig's sign. This involves flexing the hip and then attempting to extend the knee. And this will be difficult and painful in a patient with meningitis because of spasm of the hamstring muscles. Sit you up. And that concludes the examination of the central nervous system.